Alright guys, for the last of the female reproductive recorded lectures, I'm going to do all the malignant disorders into one recording. So I'll talk about, a little bit on vulvar cancer. Mostly what I'm going to talk about is going to be your cervical cancer, your endometrial cancer, and your ovarian cancer. And your breast cancer I did in a previous lecture. So if you're looking for that, you'll need to look in a different lecture. All right, so for vulvar cancer, what we're looking at here is the risk factors. And so your most common risk factors for cancer of the vulva is most commonly going to be your sexually transmitted diseases or your sexually transmitted infections. You're also going to see this with people who have immune suppression. That's a typo there. And then, of course, smoking. Smoking is a precursor for all chronic diseases, all cancers, so it's one of the risk factors also. So signs and symptoms that your patient may have some kind of vulvar cancer is persistent itching, white or red patches over the skin, skin ulcers, and wart-like growths like your human papillomavirus typically has a wart-like lesion that tends to appear. Therapeutic interventions, most of the time it's just going to be destruction of the cancerous cells, and this can be done with like liquid nitrogen. Sometimes they'll use acid preparations, something that will, physically destroy the cancerous cells on the outside of the skin. For really aggressive cancers, they can do a radical vulvectomy. If you do that, you're removing, a good portion of the skin there. And a lot of times skin grafting is going to be necessary to repair that. All right, cervical cancer, this one's got a lot of treadway, especially over the last, 20 years with the human papillomavirus and the vaccine that goes with this. So cervical cancer, most likely risk factors are going to be early sexual activity. Usually if you have an individual with early sexual activity, they also will have multiple sex partners, so that's another risk factor. Individuals that have had several pregnancies, smoking, human papillomavirus, that is the #1 risk factor that they have determined with cervical cancer, and then also herpes simplex virus #2. So signs and symptoms of cervical cancer, serosanguinous discharge. And if you think back to your early PN labs, we talked about the different types of drainage, and so the serosanguinous, that's going to be that pink drainage because it's a combination of the clear and the bloody together, so it'll make pink. But with your cervical cancers, a lot of times your individuals are asymptomatic, so they can have cervical cancer and show absolutely no signs and symptoms whatsoever until it starts getting more aggressive and advances to other areas. So diagnosis of cervical cancer is we do a pap smear, okay, and that's where the woman will have an exam done where they'll use the speculum and they'll go in and inspect the cervix. They can do a Schiller's test. This is where they paint the cervix with iodine, but the only way to confirm any type of cancer, of course, is going to be with a biopsy. So if they go in and do a pap smear, they still would have to go in later and do a separate biopsy, take a piece of the cervix, and send it off for pathology. Intervention-wise, there's a lot of things that they can do for interventions. They can do cryotherapy, which is like the liquid nitrogen. They can do laser therapy. They can surgically excise. If we're dealing with cervical cancer that has expanded into the uterus, we're looking at a hysterectomy. They can do radiation implants. They can do chemotherapy. Again, it's going to depend on how advanced this cervical cancer is. When you unfortunately find this sometimes is a lot of times when a woman goes on, when she's first starting to talk about becoming pregnant or, early on in her pregnancy, they may determine that the cervical cancer is observed then. When you have an individual that's going to go through chemotherapy, okay, especially a woman of childbearing years, it's very, very important that we put her on an effective birth control so that she doesn't get pregnant while undergoing chemotherapy, because chemotherapy obviously is very, very harmful to a developing fetus. So most of the time, while the female is undergoing her treatments, they will put her on oral contraceptives because they kick in immediately, and they're very, very effective against pregnancy. So for the endometrial cancer, this, as we kind of talked about in another lecture, endometrium is that inner lining of the uterus. And so endometrial cancer is going to be that inner lining of the uterus. Risk factors for this include excess estrogen and estrogen therapy. And that's another reason why hormone replacement therapy is so controversial, because we know that it also leads to an increased chance of endometrial cancer. Another risk factor is obesity. So signs and symptoms of endometrial cancer is abnormal bleeding. And so when we have a female who starts having bleeding outside of what her normal parameters are, it makes us a little bit suspicious, okay? So a lot of times, you know, most women know, as long as they have a normal menstrual period, what their normal flow is. So when they start having breakthrough bleeding, or they have a cycle that is heavier than usual or lighter than usual, you know, it does kind of raise a few red flags. So abnormal outside of what their normal menstrual cycle is. Diagnostic testing for this, we want to do an ultrasound, and most likely it's going to be a transvaginal ultrasound, so that the wand can go internally and look at the inside structures of that endometrial layer. And then, of course, we need to do an endometrial biopsy to confirm the cancer. Interventions here, radiation, chemotherapy. Most of the time, though, we're going to have to do a hysterectomy, and I'll talk about care for the patient following a hysterectomy in a little bit. For ovarian cancer, this one has risk factors such as low fertility, a woman who enters menopause later in life, strong family history with ovarian cancer, high-fat diet. Now, if you notice, a lot of these risk factors are also the same risk factors that you see with breast cancer. So very, very common crossover between breast cancer and ovarian cancer. Unfortunately, with ovarian cancer, these symptoms do not manifest until it has become pretty high in the staging system. So the mortality rate with ovarian cancer, unfortunately, is usually very high. Interventions for ovarian therapy or ovarian cancer is going to be radiation, chemotherapy, and then we're going to surgically remove the ovaries, known as an oophorectomy. So depending on, you know, can we salvage any of the ovary? Can we salvage one of them? But if you do remove the ovary, remember that you're going to put this woman into full-blown menopause, because the ovaries are responsible for secreting those hormones, and so the woman is not going to have those hormones if you remove both of the ovaries. So for your gynecologic surgeries, we do endoscopic surgeries most of the time. You have a laparoscopic surgery, or where they go in laparoscopically, and they a lot of times will just kind of visualize the structures themselves. You have colposcopy, which is a scope of the cervix, and you have hysteroscopy, which is a scope of the uterus. Okay. So endoscopic surgery is most likely what we're going to do for gynecologic surgery. And they are doing a lot more robotic surgeries with the gynae surgeries. So they're pretty impressive to watch, and they're pretty non-invasive compared to what they used to be several years ago. So post-operatively, following an endoscopic surgery, of course, you know, this is a surgical patient, so we're going to monitor them for any signs of bleeding, any signs of infection. So we want to look at vital signs. We're going to monitor for bleeding. We're going to assess their temperature, and we're going to assess their pain. Abdominal surgery can be pretty painful, so even endoscopically, so we want to make sure we monitor their pain level. When you do endoscopic surgery, or anytime you do abdominal surgery, a lot of times they're going to use something called insufflation, where they're going to inflate the abdomen with carbon dioxide. And when they do that, that's going to help visualize the organs, but then that gas still has to escape. So it causes a lot of pain when you have someone who has that insufflation done. So to help with the pain, or to help pass the instilled gas that they put into the surgery, we want to instruct the patient to lie flat. Sometimes that will help the gas escape. We want to administer analgesics, and then we want to teach the patient about turn, cough, deep breathing. We want to teach them about early ambulation. but not to overexert themselves until they're released by their physician to do so. All right, so I do want to talk about the hysterectomy because this is a very common surgery that they do for patients with cancer, but also patients without cancer. So for a hysterectomy, the types that you have, this can be with or without a bilateral salping oophorectomy. Bilateral salping oophorectomy means that they've taken the fallopian tubes and the ovaries as well. So when they talk about like a total hysterectomy, we're usually just taking the uterus, whereas a supracervical means that they're leaving the cervix intact and they're taking everything above that, whereas a radical means most of the time they've taken the entire uterus, and now we're looking at taking the fallopian tubes and the ovaries as well. Methods-wise, we can do abdominal, you can do it vaginally, you can do it laparoscopic, and as I mentioned, you can have this, robotically done. What you need to remember with this is when you are doing a hysterectomy is that the woman is no longer able to have a child after that. And regardless if this was an elective surgery or non-elective surgery, there's a lot of emotions that are going to come into play with this. So we want to use our therapeutic communication. We want to talk to the female about how she's feeling. And we need to, be mindful and make sure that her family understands the emotions that might be tied to this type of surgery as well. So again, the rationale for why we would do hysterectomy, it could be menstrual problems. You hear this a lot with women that have abnormal bleeding patterns. It could be a female that has developed benign tumors, so fibrocystic tumors that need to be taken out. It could be a result of prolapsed uterus, and maybe that's the only option. And then, of course, it could be related to cancer as well. So your nursing diagnosis for your hysterectomy patient, risk for ineffective tissue perfusion, risk for urinary retention because it's a surgical patient, risk for constipation from the surgery, anesthetics, and the pain meds, could be anxiety because it's a surgery. We're dealing with body image disturbance. So even though the uterus is on the inside part, a lot of women perceive the loss of their uterus or the loss of their childbearing years. They perceive it very negatively. So you do need to consider that body image disturbance. And then, of course, also risk for ineffective coping, because again, you don't know emotionally how a woman is going to react post-hysterectomy. So just kind of things to keep in mind when we're teaching and talking to our patients with a hysterectomy. Okay, and that is going to wrap up the female reproductive disorders.